Hello, friends. Today we are going to discuss the question which was asked in DRNB Critical Care exam, April 2024. And the question was about 20% albumin, 45% normal saline, and the IVH. So regarding 20% albumin, albumin is the plasma protein that is produced in the liver, which is in the physiological state and is involved in the variety of the homeostatic function. These include the maintenance of the colloidal osmotic pressure of plasma for up to 75% to 80%, acid-base homeostasis, and it is the main transport protein for both endogenous substance and the drug. Albumin also plays a role as an antioxidant, anti-inflammatory, and anti-apoptic protein. So, albumin is considered as a relatively safe, although more expensive, and alternative for volume resuscitation of ICU patients with semi-synthetic colloid. Because of its superior volume effect compared to crystalloid, it is recommended for those clinical situations where increased intravenous fluid administration is required, such as in patients with liver cirrhosis and septic shock. So the effect of albumin on mortality in liver cirrhosis depends on the indication. In contrast to the beneficial effect in patients with spontaneous bacterial peritonitis, no such a benefit has been seen in other conditions. In hospitalized patients with decompensated cirrhosis, recurrent albumin infusion to raise albumin level of more than the target level did not improve any outcome. However, patients with cirrhosis and septic shock, 5% albumin for volume resuscitation had beneficial effect on hemodynamics and short-term mortality compared with 0.9% saline. So clear recommendation for albumin are established for large volume paracentesis, ascitic paracentesis in hepatorenal syndrome and in spontaneous bacterial peritonitis of patient with advanced liver disease because albumin infusion can reduce the risk of AKI. So if you'll ask me what are the indication of albumin ICU, so there are only three major indications. The first one is large volume paracentesis, where we are removing the ascitic fluid. And if this ascitic fluid removal is exceeding for more than 5 liters, then and then only we need to administer albumin, otherwise no. The second indication for administering albumin is the spontaneous bacterial peritonitis. Third indication is hepatorenal syndrome only when we know it is the hepatorenal syndrome and no other cause. Okay, so when the patient with the liver disease, if he presented to you in ICU for the first day and the creatinine is high, and if you are suspecting hepatorenal syndrome, there is no role of albumin. Also, ulta it is recommended that we should not administer albumin for first 48 hours because if you administer albumin, it is difficult to diagnose the hepatorenal syndrome. So conversely, the hypotooncotic 4% albumin solution can worsen the outcome in patients with traumatic brain injury. So in context of this, there is a one trial which was published in 2004 that is a SAFE trial, which showed that 4% of albumin for fluid resuscitation in critically ill patient produced the similar result to 0.9% saline at 28 days. Although the albumin significantly reduced the total amount of the fluid administered. And second analysis showed that increased risk of mortality in patient with traumatic brain injury. But in contrast, there was trend towards lower mortality in septic patient receiving albumin. This led to design of the randomized control trial in patient with the severe sepsis comparing replacement of 20% albumin with crystalloid alone. So the conclusion or the bottom line of SAFE trial was, so this albumin was safe. The albumin was useful in septic patient, but not in traumatic patient. So because since this trial showed the beneficial effect of the albumin in sepsis patient, they have used the 20% albumin as a resuscitation fluid, and then they conducted the randomized trial. So this trial was Albios trial, which showed the albumin. So when they use this 20% albumin in septic patient in Albios trial, The use of albumin did not improve any 28-day or 90-day survival, but the post hoc analysis found that there is a reduction in 90-day mortality for albumin group in patients with septic shock. So there is a conflicting evidence whether we should use albumin in septic patient or not. And it should be noted that Albios trial did not investigate the effectiveness of albumin during fluid resuscitation. So in Albios trial, during early phase of volume resuscitation, the fluid were administered in both group according to the early goal-directed therapy. So after randomization, patient in albumin group received 300 ml of 20% albumin solution from day 1 until day 28 or ICU discharge, and 20% albumin was administered on daily basis to maintain the serum albumin level of 30 gram or more. So in both groups, the crystalloids were administered whenever it was clinically indicated by attending physician. The use of human albumin solution has been investigated in different phases of restrictive fluid resuscitation. And albumin administration improves the fluid removal during kidney replacement therapy. The hyperoncotic human albumin solution facilitated restrictive fluid therapy and the effectiveness of deresuscitative measures. So these are the various trial which was published in the context of albumin. In 2004, SAFE trial, which compared 4% albumin with 0.9% saline, and the outcome was the similar outcome at 28 day, and the post hoc reduces the 28-day mortality, reduce the vasopressor use in sepsis subgroup. Then in years trial was published in 2011, which was conducted specifically in septic group. They used 20% albumin with 0.9% saline, and they found no significant mortality difference. Then in 2004, Albios trial was published in severe sepsis and septic shock patients. They again compared 20% albumin and crystalloid. What they found was there was improved in MAP and reduced heart rate, shorter time to cessation of vasopressor and inotropic agent. But there was no difference in new organ failure, no difference in mortality, and post hoc analysis found reduced 90-day mortality in septic shock subgroup. Then RAS trial was published in septic cancer patient admitted in ICU, where they compared 4% albumin and lactate ringer lactate, which showed no significant improvement in mortality rate. Then Frisk trial and Ellipse trial was published. Frisk trial was published in 2021 in cirrhotic patient with sepsis-induced hypotension, which compared 5% albumin and 0.9% saline, and they found higher rate of hypotension reversal, sustained reduction in heart rate and hyperlactemia, and higher proportion of surviving patient at 1. Then Alex trial was published in 2022 again in cirrhotic patient with sepsis-induced hypotension, which compared 20% albumin and plasma-light. And according to this trial, the albumin was more effective, faster decline in lactate. There was a reduced need of dialysis, longer time to dialysis initiation, similar 28-day mortality, and it was associated with pulmonary complications. So, according to the surviving sepsis, this is the diagram, but first we will see the recommendation of surviving sepsis guideline. So, according to surviving sepsis guideline, it is suggested to use albumin in patients who required large volume of crystalloid over crystalloid alone. So, but it has got the weak recommendation. So if I want to use albumin in septic shock patient, then I will follow these algorithm. So first, I will assess the volume status, whether my patient is hypotensive, whether my patient is having oliguria. I will check the capillary refill time, passive leg raising. I'll check the lactate level. By performing bedside echocardiography, I will assess the cardiac function. And if I found my patient is hypovolemic, then I will rule out some factors like whether my patient is having traumatic brain injury or not. prolonged vomiting, excess losses of gastric juice, or whether he's having hyponatremic or hypochloremic. Because in this group, I will prefer to give 0.9% NSC. Okay. And if other way also, or if my patient is not falling into all these three category, I will start with the balanced crystalloid solution. Then after some time, I will repeat the volume status. I will do the repeat assessment of the volume status of my patient, and I'll see whether acute hypovolemia is resolved or not. If the acute hypovolemia is resolved, then I will switch to the volume replacement or maintenance phase. If the patient is still hypovolemic, then I will administer next fluid bolus of balanced crystalloid of maximum 20 to 30 ml per kg. And if I found that I'm requiring the large amount, or my patient has developed the signs of fluid overload, then I will consider 20% albumin. Now we'll see what is normal saline. So normal saline is the fundamental component of intravenous solution, which is extensively used in clinical setting. It is the crystalloid fluid administered intravenously, suitable for both adult and pediatric patients for hydration and correction of electrolyte disturbances. So normal saline is available in various concentration with 0.9% and 0.45% being most commonly used. So there are few FDA approved indication for normal saline. That is extracellular fluid replacement in case of dehydration, hypovolemia, hemorrhage, sepsis, treatment of metabolic alkalosis in presence of fluid loss, mild sodium depletion. Then additional uses are as priming solution for various procedure, to initiate and terminate blood transfusion, as a pharmaceutical aid and dilute for infusion of compatible drug additives. Then concentrations of the normal saline, 0.9% sodium chloride. It is the isotonic solution used for parenteral replacement of chloride loss that equals or exceeds sodium losses. It contains 15.4 milliequivalent of sodium and chloride ion as per 100 ml. Osmolarity is the 308 m osmol per liter, and the pH range is 4.5 to 7. Then 0.45% sodium chloride. It is a hypotonic solution used primarily for parenteral maintenance fluid rather than aggressive intravascular volume repletion. It contains 7.7 milliequivalent of sodium and chloride ion per 100 ml. Osmolarity is 154 mol osmol per liter, and the pH range is similar to 0.9% sodium chloride. Now, mechanism of action. Normal saline as crystalloid fluid, it is the aqueous solution of electrolyte and other hydrophilic molecules. It is the isotonic nature compared to the serum plasma, makes it a primary choice for fluid replacement. Unlike hypertonic and hypotonic solution, normal saline exerts minimum osmotic effect. Now, sodium ion. It is the measured extracellular fluid electrolytes critical for fluid and electrolyte distribution. Then chloride ion. It functions as buffering agent in lungs and tissue, facilitating oxygen and carbon dioxide binding to the hemoglobin. Then water. It constitutes more than two-thirds of body weight with balance maintained primarily by lungs and kidney. Sodium plays pivotal role in maintaining hemostatic concentrations and water distribution. Normal saline helps expanding intravascular volume without distributing ion concentration and causing significant fluid shift between intracellular, intravascular, and interstitial spaces. Now, regarding administration, normal saline is administered exclusively via intravenous access. Dosage consideration depend on the patient factors such as weight, age, clinical presentation, and lab finding. Monitoring should focus on lab results and clinical evaluation. Now, regarding method of administration. So, fluid bolus used in the acute care setting for rapid infusion. And it is administered through large bore peripheral lines or central line access. Now regarding for maintenance for 50 kg using the formula of 100, 50 and 25 rule. So for first 10 kg give the 1000 ml, that is 100 ml per kg. Then second for next 10 kg give 500 ml, that is 50 ml per kg. And then for remaining 30 kg give 25 ml per kg for 30. So total amount is 225 ml or 94 ml per hour. Now adverse effect. The administration of the normal saline can lead to iatrogenic fluid overload, particularly in patients with the impaired kidney function, like as those with acute kidney injury, chronic kidney disease, or patient with the heart failure. These patients should receive the intravenous fluid with caution to prevent complications. Now about potential adverse effect. There are febrile response, infection at injection site, venous thrombosis or phlebitis extending from the injection site, extravasation, hypervolemia, hyperchloremia when infusing large quantities, leading to decrease in available bicarbs or iron and resulting in net acidosis. These acidosis can cause increased serum potassium level due to transcellular shift of potassium from within cell to extracellular space. Now, effect of overuse. Overuse of 0.45 sodium chloride can cause hyponatremia and cerebral edema due to hypotonic nature, causing water molecule to migrate into areas of high sodium concentration. If an adverse event occurs, discontinuation of infusion is strongly suggested. The patient should undergo clinical evaluation. Appropriate therapeutic countermeasures should be taken. The remaining fluid should be saved for examination if contamination is suspected. Now, regarding contraindication, dilution of serum electrolyte concentration, overhydration, congested state, and pulmonary edema. Now, monitoring. Monitoring the use of normal saline involves periodic assessment of patient clinical and lab findings, including changes in electrolyte concentration, volume status, and acid-base disturbance. Significant deviations from normal concentrations may necessitate tailoring the electrolyte pattern in this or alternate solution. Dehydration and fluid overload. Observe for signs and symptoms. Elevated lactate and creatinine indicate the need for volume assessment. Now about urine output. Target the urine output for 0.5 ml per kg per hour. Indicates adequate hydration but may not be reliable in patient with renal impairment. The other objective findings are to evaluate fluid status. The high-risk patient, frequent reevaluation for those at risk of fluid overload, especially with known cardiopulmonary disease, evaluate for pulmonary edema and peripheral edema. Now about large volume infusion. Infusing more than 1 liter of isotonic sodium chloride per day may provide excessive sodium and chloride, potentially lead to hypernatremia and hyperchloremic metabolic acidosis. Now, this is the summary of these trials, which was published in the context of normal saline. So, in 2018, SMART trial was published, which compared balanced crystalloid and 0.5% saline. And the outcome of this trial was there was lower major adverse kidney events in crystalloid group. Then SALT trial was published in 2018, which compared balanced crystalloid and 0.9% saline. And the conclusion of this trial was no difference and less major adverse kidney event in crystalloid group. Then basic trial was published in 2022, which compared balanced crystalloid and 0.9% saline. They again found there was no difference in mortality and acute kidney injury. Then PLUS trial was published in 2022, which again compared balanced crystalloid and 0.9% saline, which found no difference in mortality and acute kidney injury. Thank you.